That was great. Clive and Fabrizio will now have a discussion about their talk about the CSF.
Yeah, we have a list of a neurological disorder, and you will see within 2 hours at the next presentation. But it's really new. So if you say why you have a sort of alteration in outflow of CSF, no one knows. This is very important. What my echo-Doppler woman, Ilaria, told me that a peculiar alteration in the diameter of the jugular vein is present, not only in this patient submitted to PTA, but it's a sort of a common pattern. Bilateral jugular thin hypoplasia or atresia, yeah. This is very important because this is in agreement of what is said. An overload of straight sinus, an overload of the vertebral sinus, an overload of intracranial venous veins.
I think it's not working. Without going into not being a clinician, I always find myself at a bit of a disadvantage when trying to talk about various clinical conditions. But I think it's, in answer to your question, I think it's fair to say that what we have here is a system that is not well understood. It's been neglected. We've got a regulatory system that regulates the blood and cerebrospinal fluid and all the kind of tensile and compressive forces in the brain. And this can go out of kilter in various ways. You know, if it goes a little bit out, maybe it doesn't make a lot of difference. It may go a bit further, then it can manifest itself in one way in one patient, or it might manifest itself in another way. Now, traditionally, as a neurologist who's been, as a clinician, trying to diagnose things, they're looking at symptoms that are different between groups, and then people get pigeonholed into things. And what I think has happened is that as we go down this route of understanding this whole problem, and this is why I stress again that we have to understand the physiology before we even understand the pathophysiology, we'll find that actually many of these things have overlaps and there's continuums. And that in fact, that some of the things that we see with patients who are perfectly normal and healthy, where they've got abnormal venous, so-called abnormal venous pathways, it's no problem at all until something else goes slightly wrong and changes. You know, it's, again, we had a bridge in London, I think it was called the Millennium Bridge, or the footbridge over the Thames, and they designed it and they did all the analysis in it, and then all the passengers, all the people walked across it. And something very strange happened, because once they started to get walking in line, people tend to, you know, in a crowd, they tend to march at the same pace. Then you got these oscillations, and these oscillations went up, and then the bridge started, a bit like the Tacoma Narrows Bridge, started to really change. And no problem with one or two people going across, then everything starts to go wrong, and as it went wrong, they had to shut the bridge and, you know, think what they were going to do. And we're not allowed to shoot people in the UK. We're very humane. You know, this is not like Soviet Russia. We didn't send people. We haven't got a Siberia to send people to. We're too small. But no doubt the engineers got a stern talking to and got told to sort it out. And they came up with some interesting things. And I think they basically used a technology that was not akin to the kind of earthquake thing that you use in buildings to protect buildings. In other words, you counteracted that signal. And I suspect that we have things similar to that occurring in some of these pathological conditions, but we just don't understand them.
David?
Well, we use perfusion as cerebral blood flow as synonymous. In fact, perfusion is not the movement of blood through the blood vessels. It's the movement of water through the brain. Keeping that in mind, would that change any of your flow methods?
Right, I'm going to show my physiological ignorance here. David, can you just explain again, just in simple terms for me, what that means again?
I think we visualize red cells, plasma, and
Yeah.
cells moving through the arterial capillary venous system.
Yeah.
You think of that as what blood flow means. But at least with arterial labeling, what you're actually measuring is the movement of labeled water molecules,
Yeah.
not through the blood vessels, but through the brain. So it suggests to me that really what we need to add to the model is a model that includes shunting as part of the mathematics.
Yeah. Right, now I do understand the question. There's degrees of models that you can deal with. You can look at blood as a kind of homogeneous bulk flow fluid and deal with it that way. But actually, when you get down to the capillaries, you're actually dealing with red erythrocytes that are moving through in a sea of water and other cells that are passing through. And then you have to look at the amount of oxygen that carries and how that behaves. So you can go down to that level of complexity. And in fact, I would like to go down and look at that, but that needs to be done. I alluded to it in the earlier talk, but I'll talk about it now. If you think about cells as customers, right, in the brain parenchyma, and we include the endothelia here, demanding their share of oxygen and other nutrients. And there's only so much oxygen coming down here. Well, those oxygen's carried in the erythrocytes. And if you have less fluid going through, then you've got to look at the hematocrit. You've got to look at the how many erythrocytes are passing through. It's different from maybe from the amount of the actual physical volume of the blood, as you say. But also, you've got to look at the time, because if you do a heat and mass transfer, if you get any engineer dealing with heat and mass transfer, if you pass a hot fluid through a heat exchanger where you're trying to give up the heat to the surroundings, if you push it through very fast, it won't have a chance to give up that much heat through it. If you push it through very slowly, a bit like a hot water bottle, you leave it a long time, it will lose its heat. So in other words, there's actually mass transfer issues here, which are to do with the actual surface area of the erythrocytes, the surface area of the blood vessels. So the size and diameter of the blood vessels is very important to this, and the amount of erythrocytes come into contact with that, and the duration of time. So when I see increased mean transit times, that tells me that the kind of erythrocytes have got a long time to kick around in the brain next to the endothelia, and it makes me wonder, is there a mechanism which tells the cells don't demand so much oxygen? I don't know. The question is, I just don't know the answer to that, and I suspect not many people do. But if blood's flowing slowly, I suspect there could be a mechanism where it's going to give up more of its oxygen earlier on. Having said that, that doesn't fit in very well with some of the studies that Mark Hackey's done and others that G's done, which shows actually that they're not demanding that much oxygen. So I think this needs to be looked at in much greater depth. I don't know whether that's the answer, but that's my attempt.
Well, the Zamboni model is pretty much focused on the endothelium, either what trauma to it, red cell diathesis, blood movement, but the hyperperfusion is actually showing that it's the brain parenchyma, water molecule movement that is abnormal in MS, not the mean transit time between the vessels, the mean transit time in the parenchyma outside the vessel. So it suggests a possible number model, which is it's full of erythrocyte depth that is primary.
Yeah.
Yeah.
Yeah, right. The one thing, I can't give you the answer to that. I don't know the answer to that. But what I will point out is going back to what I talk to the students about and say, well, you know, plasma is water with stuff in it. Cerebrospinal fluid is water with stuff. Interstitial fluid is water with stuff in it. And interstitial fluid in the brain, how that links in with the cerebrospinal fluid is a complex mechanism, and especially in the perivascular spaces. And there is a kind of washing of the brain parenchyma with basically water, with stuff in it. And that links in to the cerebrospinal fluid. So abnormalities in those behavior may shed light on that area. That's all I can say, really, my knowledge.
Robert.
So I wanted to make a couple of comments on the CSF flow. I think it's a definitely extremely promising area of research. And if you think from the first clinical attack to the second clinical attack in MS, one of the most prominent things that are happening in the brain of MS patients is actually not accumulation of the lesions, but it's enlargement of the ventricles. There have been studies published, including ours, which are showing that patients approximately enlarge in their ventricles 40% from the first to the second clinical attack. And we did a study of early relapsing remitting patients that we followed over 5 years, and they enlarged 70%. So, if you think about the regional brain atrophy in MS patients, the most really dramatic thing is happening in the ventricles, and that would go definitely with the whole CSF flow IMPH hypothesis. In a work that we are collaborating with Clive, I think we went further, and we are showing for the first time that pulsatility index of the CSF flow is correlating very strongly with number of relapses in the last year of the patients we examined. So who has more? So we are finding a very stable CSF flow in healthy people, but much pulsatile flow in MS patients, and there is clearly the difference between different forms of patients. So people who have more, whether it's on a negative or positive side of the pulsatility, they have more relapses, they have more lesions in the brain, higher T2, T1 lesion volume. So I think it's a very promising area of research, probably less controversial than the CCSVI, although it's indirectly connected with the CCSVI, and I think might be definitely much more accepted by the neurological community if we are and others are able to show that they are really the important CSF drainage impairment problem, and that those are clinically relevant, and that's what we are finding in the preliminary studies. Just another point, and that is that all these studies needs to have reproducibility assessed, because it really, if you take the Sandstrom study, which said there is no CSF flow difference, they had very primitive methods how to measure the CSF flow. So I think that, clearly not much again has been done on this aspect, because that has not been in the domain of imagers to really show how reproducible these techniques are and how they are changing over time, which is extremely important to show, because I think the ideal study would be to show from a first clinical attack that the ventricles are enlarging and that CSF flow is changing dramatically in these patients to the second clinical attack.
Very good. So Fabrizio, it's interesting to have this it's a small group of patients that you have with CCSVI, hydrocephalus, and you're saying that their anatomical derangement of their veins is long and tubular narrowing. Is that what I'm hearing?
Yeah.
And that how do you treat those long tubular narrowings? How did they do that?
They tried to open
The whole
balloon,
vein?
Yeah.
Oh, Clive, can you Do you see any difference between the the dynamics here of a large, long, expanded tubular column that comes down to a typical CCSVI stenosis, which is in the area of the valve, and which then therefore has numerous collaterals in a large pool spaced, and compare that to a vein that's very narrow and tubular and probably still has collateral connections, but do you think there might be some differences in the flow dynamics, or is it just still dumb?
Oh no, the flow dynamics are the same. The laws of physics apply, the same principles apply, but what you're going to find is that in each case they're going to be different. But the more tortuous the tube, basically the greater the resistance. So if you've got a tube that I saw there, and I couldn't really see it very clearly, but it looked not very streamlined at all, then it's much more likely that you're going to get much higher pressures at the top end of that. What you've got to realize is that you can actually get a good indicator of what's going on by looking at the pressures at various parts in the system. But something of that complexity is a very, very poorly, from a fluid dynamics point of view, a poor exiting situation. I'd like to actually, at this point, Paolo is not here. I don't know what Paolo is going to say, but I've been working with Paolo on his work with plethysmography. And I don't want to spill the beans on that because we've written the paper and we're trying to put this in. But I'd like to just say something because it fits in at this point. What basically has happened is they take patients back, put a neck collar on, and see how it expands. It's not constricting, it's just passive. And then set them up to the vertical position. I've had this done to myself. I've been a guinea pig on this. And the blood drains away very, very quickly in the healthy controls. But in the MS patients, and we've seen great variance, it flows away much slower, but it actually flows and then kinks and changes. Now, my analogy to this is, now I'm going to be lower the tone here. We talk about toilets in the UK. I think lavatories is the thing here, but you know, if it's blocked, you know, or some way occluded, when you put the flow down, what happens to the bowl? You know, water's still going out, but it starts to back up, doesn't it? Depending on what's down there. We won't go into the details of that, but we've all been there. You can tell I'm an engineer. We go into, you know, places other people don't go. But the point is, it's a rate of change. So in other words, if you have blood trying to get down something that's tortuous, then it will start to back up, basically, and you'll get those pressure increases. So the same analogy applies to, and those look pretty bad, those routes did.
Yeah, I would suspect that those long tubular narrowings, if they are really it's either hypoplasia or a diffuse inflammatory process. I don't know what else it could possibly be. Probably hypoplasia. That's a very different column. There's probably very little compliance at all for that vein. Very different than the jugular vein.
Yeah, no, that's something I think you need to look at. I mean, it depends how it got there. I mean, if it had actually by kind of almost like angiogenesis, if it had kind of changed and there's some scar tissue there, the compliance will change. And certainly there was a paper given in Bologna which showed that the collagen 3 component above where a stenosis is, a chap from Geneva, I forget his name, but I talked to him quite carefully. And what you get is collagen 3 is when you get repair of tissue. And if you've got pressure like this, that's implying that the tissue is constantly trying to repair itself. The fibroblasts are trying to repair themselves, and that they're not managing. They're laying down collagen 3. If you get scar tissue, what happens is you lay down the collagen 3, then you remodel it to collagen 1. So if you're having that going on, the compliance of that tissue will change in that route. But also, if you've got tight radiuses, which it seemed to have there, then the compliance of those tissues will change again. So I suspect that the compliance is not so good, and if the compliance is not good, then things go further up and change there, which I hope no one asks me about normal pressure hydrocephalus. I'm not going to be able to talk about it without gelling up on it, but I suspect that will have a knock-on effect further up, which might explain what's going on.
I think this hypoplasia is a very interesting issue because it's very uncommon. The vast majority of patients who have venous stenoses do not have this, so it may be a unique subset to look at for some of the other issues. Any other questions? Well, we'll break for lunch. We'll reconvene at 1:45. If you get a moment, either before lunch or after lunch, please go visit the exhibits. They've been very helpful in supporting the meeting, which we need to have that kind of support. So thank you.